Welcome to the Hospital Medicine Unplugged podcast. Today, we are undertaking a critical deep dive into an area of, I think, immediate and high-stakes decision-making for our hospitalized stroke patients. We're talking about the evidence-based application of single antiplatelet therapy, or SAPT, versus dual antiplatelet therapy, DAPT, for secondary stroke prevention.
This is truly a high-wire act, particularly for hospitalists managing these acute admissions. The fundamental challenge is you're balancing two intensely time-sensitive risks. On one hand, you have to aggressively combat the high early stroke recurrence risk, which, as the literature tells us, peaks intensely within the first 48 to 72 hours. But on the other hand, you have to do this without pushing the patient over the edge into a major, potentially catastrophic hemorrhagic event.
That balancing act is everything. The optimization of benefit over bleed risk really defines our entire discussion today. So I think the mission of this deep dive is to synthesize the current guidelines, the landmark trial data that really built those guidelines, and also the emerging evidence that's already starting to challenge them. Yeah. We want to clearly define exactly who should receive DAPT, what the optimal duration is, and maybe most critically, when we must strictly avoid it. Because the wrong antiplatelet decision can cause immediate harm.
It can. Yeah. And antiplatelet therapy is, central to mitigating that recurrent ischemic risk, but only for a very specific type of patient.
The noncardioembolic stroke patient.
Exactly. The mechanism has to involve platelet activation in an underlying atherothrombotic process. That distinction, based on the stroke mechanism, is the absolute foundation of our therapeutic strategy.
So if we initiate DAPT, what are we assuming?
We are presuming the patient's stroke mechanism is fundamentally related to plaque disruption and the platelet aggregation that follows, whether that's in large artery atherosclerosis or even smaller vessel disease where there's a thrombotic component. If we miss cardioembolic source, say an occult atrial fibrillation or a left ventricular thrombus, the entire antiplatelet strategy is not just ineffective.
It's actively harmful.
It's actively harmful. It exposes the patient to unnecessary bleeding risk while completely failing to prevent the next and likely more severe embolus. This is why that early and definitive stroke workup is just inseparable from the decision to start DAPT.
Okay, let's unpack this and start by establishing a clear vocabulary. We use the terms SAPT and DAPT constantly, but what exactly are the typical regimens that fall into these categories in the modern stroke management world?
So SAPT, or monotherapy, involves one primary agent. Right. Most commonly, that's aspirin, with a pretty wide dose range, usually prescribed between 50 to 325 milligrams daily.
Okay, and the other options?
Alternatively, SAPT might be Clopidogrel, the P2Y12 inhibitor, dosed at 75 milligrams daily. And then the third major option, which we primarily see for long-term SAPT, is the combination product of aspirin 25 milligrams plus extended-release dipyridamole 200 milligrams, taken twice daily.
And that one has some tolerability issues, right?
It does. That regimen, while effective, often suffers from lower patient tolerance due to headache, which is a really key clinical consideration for long-term adherence.
And DAPT, dual antiplatelet therapy, in this context of acute stroke prevention, is very narrowly defined, primarily focused on platelet inhibition at two different pathways.
Precisely. DAPT for acute stroke prevention almost exclusively refers to aspirin, which inhibits thromboxane A2 via COX-1, combined with a P2Y12 inhibitor, which blocks the ADP receptor on the platelet surface.
And the most common partner for aspirin is Clopidogrel.
Yes. While we will discuss ticagrelor as an alternative, the most common and longest studied combination remains aspirin plus Clopidogrel. And as we emphasized at the start, this strategy is only for non-cardioembolic ischemic stroke mechanisms. If the patient has a known cardioembolism, oral anticoagulation, typically a DOAC, is a universally preferred and superior strategy.
Right. Ignoring that mechanism and treating with DAPT is a fundamental error.
A fundamental error.
That brings us directly to patient selection, which is governed by really strict evidence-based criteria. The American Heart Association, American Stroke Association guidelines are highly specific about who qualifies for DAPT, and they underscore that this is, without exception, a short-term strategy.
Yes, they are very precise. This is not for everyone. The guidelines restrict DAPT to populations deemed to be at the highest immediate risk of recurrence in the days following the event.
And we're looking for two specific clinical profiles here, both of which come from those landmark trials.
Correct. The first group is patients with a minor non-cardioembolic ischemic stroke. And this is clinically defined by a National Institutes of Health stroke scale, or NIHSS, score of less than or equal to 3.
A score of 3 or less, why that number?
That score reflects a minimal neurological deficit. It suggests a smaller area of infarction and often a less severe overall insult, which is key to managing the hemorrhagic risk. A larger stroke means more damaged brain tissue that's prone to bleeding.
Okay, that makes sense. And the second profile is the TIA patient who is, teetering on the edge of a major stroke.
Right. The second profile is a high-risk transient ischemic attack, or TIA, and that's defined by an ABCD² score of 4 or greater.
Let's quickly break down that score for everyone.
It's a vital tool because it aggregates multiple risk factors. A is for age over 60, B is for blood pressure, C for clinical features like unilateral weakness, D for the duration of symptoms, and the second D is for the presence of diabetes.
And a score of 4 or more signals high risk.
Yes, a score of 4 or greater indicates a 30-day stroke risk exceeding 4%, and that justifies the aggressive dual therapy approach.
The urgency of initiation is what really dictates the success of this treatment. Given that the highest risk of a subsequent stroke is packed into the first 48 to 72 hours, is there an ideal time frame, say from symptom onset to loading dose?
There is. The clock starts ticking immediately. If a patient meets these criteria, early initiation in the hospital is critical, ideally within 12 to 24 hours of symptom onset. The benefit of DAPT is essentially front-loaded. It maximizes the inhibitory effect during that hyperacute period where platelet aggregation is most aggressive near the culprit lesion.
We've established the inclusion criteria, but now let's pivot to the essential exclusions and contraindications, because giving DPT to the wrong patient is where we turn potential benefit into guaranteed harm.
The first and most crucial exclusion is the stroke mechanism itself. DAPT is absolutely contraindicated for cardioembolic stroke.
So that requires a comprehensive workup to rule out things like AFib, flutter, or intracardiac thrombi.
Exactly. If we identify, for example, atrial fibrillation, then oral anticoagulation is the superior strategy for secondary prevention. Introducing DAPT would only increase the hemorrhage risk without addressing the embolic source.
Beyond cardioembolism, there is a specific noncardioembolic subtype that warrants strict avoidance of DAPT, which I think is a frequent source of confusion when distinguishing between large and small vessel disease.
That would be the lacunar stroke, the classic presentation of cerebral small vessel disease. This subtype has to be explicitly mentioned as a contraindication for DAPT, and for that, we have to look back at the SPS3 trial.
The secondary prevention of small subcortical strokes trial.
Yes. That trial fundamentally changed practice for this subgroup. It was designed to see if adding Clopidogrel to aspirin would improve outcomes for patients who had a recent lacunar stroke. The results were unequivocally negative on the efficacy front.
And the safety signal was clearly alarming.
Precisely. The trial found that dual therapy provided no reduction in recurrent ischemic stroke, but critically, it increased major hemorrhage by almost twofold.
Twofold, that's a huge signal.
It's a profound distinction. It tells us that the pathophysiology of a pure lacunar occlusion, often something like lipofilanosis or microtheroma, it just doesn't respond favorably to this aggressive antiplatelet combination. The treatment only adds risk. So if the mechanism is pure lacunar disease based on imaging and the clinical picture, DAPT is a hard pass. Single antiplatelet therapy is the standard.
That clears up the mechanism-based contraindications. What about patient-specific factors that elevate bleeding risk?
We have to perform a rigorous assessment of inherent bleeding risk before we start.
Right.
Patient factors that would contraindicate or at least mandate extreme caution include a recent active gastrointestinal bleed, especially within the last 6 months. Known thrombocytopenia, severe uncontrolled hypertension, or
evidence on imaging of a large infarct that might be prone to bleeding.
Right. A large infarct with a high potential for hemorrhagic transformation. Patients with larger cerebral infarcts are inherently at greater risk of hemorrhagic conversion due to vessel wall damage, meaning DAPT is inappropriate. We might need to rely on SAPT or even delay therapy entirely, depending on the severity of the lesion.
Okay, let's transition into the practical aspects of implementation. Dosing and timing. So assuming the patient meets the NIHSS score of 3 or less, and we've confirmed a non-cardioembolic, non-lacunar mechanism, what is the established DAPT initiation protocol?
To maximize efficacy within that crucial 72-hour window, we have to achieve rapid and profound platelet inhibition. That means loading doses are mandatory.
What are those doses?
The established regimen involves loading aspirin, usually 325 milligrams, and clopidogrel at 300 milligrams. Some institutions use a higher 600 milligram clopidogrel load, which can achieve faster platelet inhibition, but the 300 milligram dose is the generally accepted minimum standard based on the pivotal trials.
And once the patient is loaded, what is the maintenance regimen?
Maintenance involves transitioning to low-dose aspirin, typically 81 milligrams daily, plus clopidogrel 75 milligrams daily. This regimen continues for the defined short-term duration, which we're about to analyze.
We've stressed the critical nature of timing. We said early initiation is vital, but let's dive into the data on the timing window. How much benefit do we actually lose if the patient gets DAPT at 48 hours instead of 12 hours?
The magnitude of benefit is greatest when initiation occurs within 24 hours of symptom onset. That's when the risk is peaking and the intervention has maximal impact.
But it's not a hard stop at 24 hours.
No, it's not. The evidence shows that benefit can extend up to 72 hours. The CHA-NCE2 trial in particular showed this. While the reduction in stroke recurrence is smaller compared to initiating within the first day, it still offers a relevant window, especially for patients who present later.
And beyond 72 hours.
If we start DAPT beyond about 7 days, the benefit is essentially negligible, and we're just exposing the patient to unnecessary bleeding risk.
Okay, before we dissect the landmark duration trials, let's address a key practical dilemma in the hospital. Managing antiplatelet therapy in the patient who received intravenous thrombolysis, either alteplase or tenecteplase.
Right, this is a scenario where caution has historically reigned supreme. For patients receiving IV thrombolysis, antiplatelet therapy, including DAPT, is traditionally delayed for a mandatory 24 hours. This is a critical safety measure to minimize the risk of symptomatic intracranial hemorrhage post-thrombolysis. We wait for follow-up imaging, a CT or MRI, to confirm there's no bleed before we start.
But I understand there's emerging data that's challenging the necessity of that 24-hour delay, specifically in minor stroke.
That's right, and it points to a fascinating area of evolving practice. The EAST trial, that's the early antiplatelet treatment in minor stroke, or TIA, after intravenous thrombolysis trial, it investigated this directly. It looked at initiating DAPT within 6 hours post-thrombolysis, rather than waiting 24 hours in patients with minor stroke or TIA.
And what did they find from a safety perspective?
The results were reassuring. Initiating DAPT early was safe. It did not increase symptomatic intracranial hemorrhage or major systemic bleeding compared to the delayed group.
Safety is paramount, of course, but for practice to change, we need to see improved outcomes. Did they demonstrate that starting 18 hours earlier provided a meaningful clinical benefit?
Unfortunately, no, not significantly. The primary endpoint of excellent functional outcome at 90 days was nearly identical between the two groups.
So it's safe, but not necessarily better.
Exactly. It suggests that while delaying 24 hours might not be strictly necessary for safety in these very specific patients, starting it early doesn't seem to provide substantial additional functional benefit, likely because their baseline prognosis is already excellent. So for now, the trial gives us confidence that the standard 24-hour conservative practice is safe and sufficient.
Now we arrive at the evidence that define the duration debate, the landmark CHA-NCE and POINT trials. These two studies are really the cornerstone of the DAPT guideline.
They are. The CHA-NCE trial and the POINT trial established the entire foundation for short-term DAPT. They both had the goal of treating patients in that highest risk period immediately following a minor event.
Let's start with CHA-NCE, which tested a 21-day duration.
CHA-NCE was groundbreaking. It included patients with minor stroke, so NIHSS of 3 or less, or high-risk TIA with an ABCD² score of 4 or greater. The intervention was clopidogrel plus aspirin for 21 days, followed by clopidogrel monotherapy.
And the results were pretty compelling.
Very compelling. Dual therapy significantly reduced 90-day stroke recurrence. In a later pooled analysis, we see stroke recurrence drop from about 11.7% in the aspirin alone group to 8.2% in the DAPT group. And crucially, CHA-NCE showed this reduction without any statistical increase in major hemorrhage. The safety profile looked excellent.
So that led to a lot of optimism about DAPT.
It did.
And then the POINT trial came along, testing the same population, but with a much longer duration. What happened when they stretched the dual therapy out to 90 days?
POINT used the exact same high-risk population, but extended the DAPT duration to 90 days. And like CHA-NCE, it showed efficacy. It reduced the rate of recurrent ischemic stroke, MI, or death from an ischemic vascular cause.
But this is where the safety signal became very sharp and alarming.
Exactly. This is the key difference. POINT demonstrated a significant downside. Major bleeding was more than doubled, rising from 0.4% with aspirin alone to 0.9% with DAPT. This resulted in a striking hazard ratio of 2.32 for major hemorrhage. And that result immediately pumped the brakes on enthusiasm for the longer DAPT duration.
So if the benefit is front-loaded, stretching the drug combination out past the point of maximal ischemic risk simply maximizes the cumulative bleeding risk.
That is precisely what the pooled analysis of CHA&CE and POINT confirmed. Researchers examined the time-dependent benefit. The ischemic event reduction was largest, with a hazard ratio of 1.66 in the first 21 days. This is where the aggressive dual inhibition is most effective.
And then the critical finding that defines current practice.
Yes. They observed that after 21 days, the benefit essentially vanished, with a hazard ratio of 0.94 for recurrent ischemic events. Meanwhile, the hemorrhagic risk just kept compounding day after day.
So the conclusion from the combined data is that we maximize the ischemic stroke prevention in the first 3 weeks when the patient is most vulnerable.
Right. But beyond that, we start racking up bleeding risk without getting any proportional stroke protection.
That analysis really seems to suggest that the optimal DAPT duration to maximize the net clinical benefit should be 3 weeks or 21 days.
It does. The 21-day course strikes the best balance. The benefit of preventing ischemic events in the second and third weeks is still positive, but when we push past that, particularly toward the 90-day mark, the cumulative leading cases start to outweigh the marginal strokes prevented. This is why the AHHSA guidelines state 21 to 90 days, but the meta-analyses really support aiming for the shorter 10 to 21-day course to optimize that net clinical benefit.
And what is the absolute hard ceiling for DAPT, regardless of the patient's underlying risk factors?
The hard ceiling is 90 days. The key principle is that DAPT beyond 90 days is strictly not recommended. It provides no additional stroke risk reduction compared with SAPT, but it significantly increases major bleeding risk, with a relative risk around 2.42.
So the message is clear. Short-term DAPT is a crisis intervention, not a maintenance strategy.
Exactly. Once the acute crisis period is passed, the risk-benefit profile flips dramatically against dual therapy.
While clopidogrel and aspirin is the default regimen, we should address the alternative involving ticagrelor based on the THALES trial, which broadened the inclusion criteria a bit.
Yes, the THALES trial offered an alternative DAPT approach. The regimen tested was ticagrelor 90 milligrams twice daily plus aspirin for a duration of 30 days. And notably, the indication was slightly broader. It's FDA approved for acute ischemic stroke with an NIHSS score of less than or equal to 5 or high-risk TIA.
So that NIHSS of 5 or less extends the indication past the strict 3 or less for clopidogrel DAPT. Did it show similar efficacy?
It did. It showed a reduction in stroke or death at 30 days. This confirmed ticagrelor aspirin is also an effective dual therapy. However, like POINT, the safety profile demands attention. The ticagrelor aspirin combination is associated with a significantly higher bleeding risk.
How significant was that increase in bleeding?
It was substantial. The THALES trial showed severe bleeding was significantly increased, from 0.1% with aspirin to 0.5% with dual therapy. That's a hazard ratio of nearly 4 for severe bleeding.
4? Wow.
Yes, and intracranial hemorrhage was also significantly increased, roughly 4-fold. So while THALES was positive for efficacy, the major bleeding rates were a clear drawback. It hasn't universally replaced clopidogrel. It's often reserved for specific scenarios where clopidogrel might fail.
That severe increase in bleeding risk with ticagrelor really begs the question, why would we ever choose it over the clopidogrel aspirin regimen?
This is where we have to talk about pharmacogenetics, specifically the role of CYP2C19 polymorphism. This is maybe one of the most fascinating clinical genetic interactions in stroke medicine. Clopidogrel is an inactive prodrug. It requires metabolic activation, primarily driven by the liver enzyme CYP2C19, to become active.
And if a patient has variants of this enzyme, the activation process fails.
Correct. Patients with what are called loss-of-function variants of CYP2C19 are poor metabolizers. They can't activate the drug effectively. Ticagrelor, on the other hand, is not a prodrug. It's not dependent on CYP2C19 for its immediate inhibitory effect. So in a known poor metabolizer, ticagrelor offers a functional, immediately active alternative.
And this issue of poor metabolizers isn't uniform across ethnic groups, which is a vital clinical consideration.
Exactly. These loss-of-function variants are present in roughly 25% of white patients. But strikingly, the prevalence is much higher in East Asian populations, affecting up to 60% of patients.
So that has huge implications for treatment choice in certain populations.
It does. Evidence from trials in Chinese patients with these variants showed that ticagrelor or aspirin was indeed more effective than clopidogrel aspirin in reducing recurrent stroke. This makes pharmacogenetics a very powerful tool.
Given that, is routine genetic testing for CYP2C19 required or even common clinical practice in the acute setting?
No, currently, routine genetic testing is optional and not universally required. It's largely due to the time and cost involved in getting results back in that acute stroke window where decisions have to be made in hours.
But it should still guide our choice in certain scenarios.
Absolutely. Clinically, if you have a patient from a high prevalence population, or perhaps more definitively, a patient who has a recurrent ischemic event while already compliant on long-term clopidogrel monotherapy.
A clopidogrel failure.
A clopidogrel failure. In those cases, genetic testing becomes highly relevant, and switching to ticagrelor is a strong data-supported strategy.
Let's briefly review the agents and combinations we should actively avoid in this setting.
First, we should generally avoid triple antiplatelet therapy. This is strongly discouraged, for example, aspirin, clopidogrel, and dipyridamole, due to excessive bleeding risk without providing any demonstrable additional benefit for stroke reduction.
And second, the incorrect application of our newer oral anticoagulants.
Yes, we have to keep reminding ourselves that DOACs are for cardioembolism. They show no benefit over antiplatelet therapy in patients with ESUS, embolic stroke of undetermined source, or noncardioembolic stroke. The guidelines are crystal clear. DOACs should not be used in the ESUS population unless a subsequent cardioembolic source is discovered.
We've established that the preference is 21 days of DAPT for most minor stroke or high-risk TIA cases. But now we enter the gray zones and the areas of evolving science, starting with the complex and high-risk subgroup of large-artery atherosclerosis.
This subgroup represents a fascinating challenge to that standard 21-day rule. For patients with large artery atherosclerosis who meet the minor stroke criteria, the conventional duration has been 21 to 90 days. But the thrombogenic nature of significant plaque may persist beyond that initial 3-week window.
And emerging data is now directly challenging the hard 90-day stop date for this specific vascular subgroup.
It is. The initial data is highly provocative. A recent retrospective analysis, and we have to stress that this is retrospective, so we need caution, it looked at nearly 5,000 patients with acute ischemic stroke definitively caused by large artery atherosclerosis.
And what did it find?
They found that continuing DAPT beyond 3 months, so beyond 90 days, and extending it up to 6 months, resulted in a reduction in a critical composite outcome that included recurrent stroke, MI, major bleeding, and all-cause death.
That is a startling finding because it suggests that in this population, prolonged DAPT reduces both ischemic events and, counterintuitively, major bleeding and all-cause death. How would extending DAPT not increase bleeding risk in this group?
That is the pivotal question.
Yeah.
It implies that in large artery atherosclerosis, where you have a high burden of complex inflamed plaque, the thrombogenic risk is sustained for much longer. If the underlying mechanism is that highly prothrombotic, the relative benefit of the antiplatelet protection may continue to outweigh the absolute bleeding risk for a longer period.
So we might be looking at a future where we phenotype the stroke.
Yeah.
If it's a minor stroke of unknown origin, 21 days. If it's high-grade symptomatic large artery stenosis, the duration could be extended.
That's the evolving paradigm. This is particularly relevant when we consider patients with significant intracranial stenosis.
And here, the SAM-MPRI trial gives us strong foundational data.
Indeed. The SAM-MPRIS trial is critical. It established that aggressive medical management, which included 90 days of aspirin and clopidogrel, was superior to stenting for patients with severe intracranial stenosis. The medical management arm successfully demonstrated that DAPT for 90 days, combined with intensive risk factor modification, achieved a significantly lower recurrent stroke rate than had been seen in earlier trials with aspirin alone.
So for that specific subgroup of severe symptomatic intracranial stenosis, the 90-day duration is strongly supported by level 1 evidence.
It is.
Moving past medical management, what about post-stenting antiplatelet management in general?
For patients undergoing intracranial stenting, the protocol established 90 days of clopidogrel plus aspirin as the standard practice. For extracranial carotid stenting, the duration is less evidence-based but often mirrors coronary stenting protocols, usually 1 to 3 months.
And for mechanical thrombectomy, what's the recommendation when no stent is left behind?
There are currently no specific guidelines recommending DAPT duration after thrombectomy without stent placement. If the patient's underlying stroke mechanism doesn't meet the DAPT criteria, For example, if they had a large vessel occlusion removed, but the resulting infarct size is large, then single antiplatelet therapy is the typical practice.
Let's discuss bleeding risk in specific vulnerable subgroups, starting with advanced age, the elderly, those over 75.
This is a daily dilemma. Advanced age inherently increases the absolute risk of bleeding. The incidence of major hemorrhage will be higher. However, network meta-analyses repeatedly show that the relative benefits of antiplatelet therapy for secondary prevention are generally maintained in older adults. Their risk of recurrent stroke is also high, so the number needed to treat remains favorable.
So we shouldn't necessarily withhold DAPT based on age alone, but we need to be extremely careful with duration.
Exactly. The need for careful selection is amplified. We should be rigorously adhering to the shortest effective DAPT course, favoring the 21-day duration in the elderly.
What about patients with chronic kidney disease, or CKD?
CKD is complicated. It's a dual risk state, prothrombotic and prone to bleeding. Antiplatelet use in this population is associated with an expected relative increase in major bleeding, a relative risk of about 1.35.
But we still use it.
We do. Despite this elevated risk, low-dose aspirin is still fundamentally recommended for secondary prevention in CKD patients because the absolute benefits of reducing serious ischemic events substantially exceed the potential harm. And a key practical point is that antiplatelet therapy doses generally do not need modification based on a decreased estimated glomerular filtration rate.
Finally, let's revisit the complex issue of antiplatelet use after a prior hemorrhage, which presents a significant barrier.
This is the paradigm shift brought about by the REST-ART trial. Historically, if a patient had a primary intracerebral hemorrhage, antiplatelet therapy was avoided for life. REST-ART looked at survivors of a prior ICH who needed secondary prevention. It found that initiating or reinitiating antiplatelet agents might not increase the risk of recurrent ICH compared to completely avoiding them over a 2-year period.
That's really counterintuitive to traditional thinking.
It is. It suggests that for some survivors of an ICH, the benefit of preventing a major ischemic stroke, or MI, might outweigh the risk of recurrent ICH. Current guidelines now often state that antiplatelet agents may be reasonable after an ICH, provided the cause is controlled. It moves the paradigm from absolute avoidance to careful, calculated risk-taking.
We've established the duration limits for the acute intervention. Now let's discuss the inevitable transition. The patient is stable, the 21-day or 90-day DAPT course is complete. What happens next? We enter the indefinite SAPT phase.
Exactly. After the short-term DAPT course is complete, we transition the patient to an indefinite SAPT regimen for long-term secondary prevention. This is necessary because the patient still carries a lifetime risk of recurrence.
What are the best long-term options, and is there a clearly preferred agent when we're balancing efficacy and safety over decades?
The 3 main long-term options remain: aspirin, clopidogrel, or the combination aspirin extended-release dipyridamole. And while all 3 are effective, the long-term choice heavily leans toward clopidogrel monotherapy for many patients, specifically because of its favorable safety profile.
Can you elaborate on that safety advantage? Does clopidogrel truly separate itself from the others over the long run?
It does, according to robust network meta-analyses. Clopidogrel monotherapy caused significantly less major bleeding and, critically, significantly less intracranial hemorrhage than aspirin dipyridamole, or continuing the harmful aspirin-clopidogrel combination long-term.
And its efficacy is comparable?
Yes. Clopidogrel provides similar efficacy to aspirin dipyridamole for net clinical benefit. But the reduced bleeding risk, especially the reduction in serious intracranial hemorrhage, is a major advantage for indefinite long-term use.
That's a crucial takeaway for hospital discharge planning. If a patient tolerated clopidogrel during the DAPT phase, continuing that as monotherapy long-term offers a strong data-backed safety advantage.
That is the data-driven conclusion. The goal of indefinite therapy is prevention without complication. Since continuing aspirin clopidogrel beyond 90 days is associated with significantly higher major bleeding risk, stopping the aspirin and continuing the clopidogrel monotherapy often represents the best blend of efficacy and safety.
Finally, one clinical curveball. The patient who is already taking aspirin for primary prevention when they have their stroke or TIA, how does this impact our selection of the long-term agent?
That patient profile introduces a significant amount of uncertainty. We currently lack clear, robust evidence to guide the optimal switch. We don't know definitively whether simply escalating the aspirin dose or completely switching to a different agent, like clopidogrel, provides superior benefit.
So it comes down to clinical judgment.
It requires highly individualized clinical judgment. Given that the initial aspirin regimen failed, many experts would argue against continuing aspirin monotherapy and would favor switching to clopidogrel, provided the patient is not a CYP2C19 poor metabolizer.
We have completed an exhaustive review of antithrombotic therapy in the acute hospital setting. The key clinical decision points are systematic. Assess the severity and source using NIHSS and ABCD² scores, confirm a non-cardioembolic source, initiate DAPT within the acute window with loading doses, and prioritize the shortest effective duration aiming for 21 days for most.
What truly stands out in this deep dive is the complex kinetics of risk versus benefit. The early efficacy of DAPT is undeniable, concentrated almost entirely within the first 3 weeks. But the risk-to-benefit ratio flips dramatically after that point.
And we've seen that the traditional 90-day duration supported by earlier guidelines is now generally abandoned in favor of 21 days to maximize the net clinical benefit and reduce that unnecessary exposure to bleeding. Yet, for highly specific subgroups, like patients with complex plaque in large artery atherosclerosis, new evidence suggests that the thrombogenic environment is sustained, potentially warranting a longer duration. This highlights that successful stroke treatment must move beyond one-size-fits-all duration limits and really adapt based on the underlying vascular pathology we identify.
So for you to consider and explore on your own, given the emerging, albeit preliminary, data suggesting patients with symptomatic large artery atherosclerosis may truly benefit from DAPT extended up to 6 months, how should this evidence factor into your institutional protocols? How do you manage a patient who meets the NIHSS of 3 or less criteria, but also has high-grade ipsilateral large artery stenosis? That specific overlap may soon demand a deviation from the general 21-day rule, forcing us to integrate detailed vascular imaging right into our duration prescription.